Today, Blue Cross Blue Shield of Louisiana is hosting a patient-centered medical home summit where we're bringing multiple stakeholder groups in from around the country, actually, to talk a little bit about healthcare reform.
A patient-centered medical home, it's not a place, but it's a different way of organizing, delivering, and reimbursing for healthcare. And it's basically focused on 7 key principles that were developed by the primary care specialty organizations and some very large employers and health plans about 5 years ago. And basically, I'll go through these very quickly because they're important. Number 1, you have to have a good personal relationship with the physician to get good outcomes, to get better quality of care. Number 2, physicians can no longer just work as individuals taking care of individual patients. We have to work as teams, and we have to take care of populations of patients, and we have to be more patient-centric, meaning the patient's at the center of the care instead of the provider like it is today. Third, we have to really improve our coordination of care. Today, there's people falling through the cracks all the time, and that's why ER visits are up 40% in the last 10 years, and 50% of those could have been seen at a lower level, much less costly level of care, and why 20% of people admitted to hospitals are readmitted within 30 days, and 50% of those had never seen a physician in follow-up. So we got to improve the coordination of care. And inherent in this patient-centered medical home model is this patient care coordinator. They're the navigator. They're the ombudsman. They're the person who helps guide patients through the system and helps them get care at the right place, right time, et cetera. Next, we have to have a much better access of care. Patients today, they're using the ER, unnecessarily. So we got to improve access. But right now, there's only so many primary care physicians to go around. We've got this chronic disease epidemic that we're facing at the same time. So it's a kind of a supply and demand thing. So we have to leverage new technologies to get access to care. Because in the future, it's not going to be just seeing your doctor face-to-face anymore. We're going to be using, leveraging technology like iPhones, online visits, e-visits, group visits, things of that nature, because that's how we're going to have to do it to avoid this reduction in PCPs, primary care physicians, that we're going to be seeing in the next 20 years. The other thing is we have to have good quality of care. Like I said earlier, quality of care is not very good in America relative to other places. So we have to focus on improving quality, and if we give them the right incentives and we use data in a proper method, we're going to get better outcomes. And lastly, we need to provide better reimbursement for the physicians who are doing all this work, and that's where we're going to start doing this care coordination model, pay them money to do care coordination, continue with the fee-for-service payment as today, but decrease that over time, and then have a shared savings model around reducing total cost for the population as well as meeting good quality standards. So it's really a very different paradigm than what we have today, but I think it's really going to be the wave of the future.
The piece that's been left out of healthcare reform and the PPACA legislation was how we're going to address the affordability crisis. So here in Louisiana, it's important that we take the message to the marketplace, specifically to the provider community and to the general public, and illustrate to them that there is a change in the horizon, that we will look for ways to address the affordability crisis and find ways to better spend healthcare dollars with better outcomes and better patient satisfaction.
My message is that we need to move to a model of care called the patient-centered medical home that allows for much better access for our patients, flexible scheduling, open access, that allows for much better patient engagement with their healer, that allows for follow-up and follow-through coordination, integration of care across specialty, primary care, and hospital care. And we need to move away from just buying an episode of care based on a fee-for-service. We need to begin to pay for better value, better outcome, using this wonderful model called the patient-centered medical home, which is agreed upon by all of organized primary care to begin to move to.
The message is that the current delivery model in America is broken. It's not providing the results that employers deserve for the money they're paying, that individuals who buy their own health insurance deserve for the money that they're paying. So we need to provide better value to these key stakeholders in healthcare. So the idea is we need to change the delivery model that's focused on providing better value. And the way we're going to do that is to really bring back primary care, because a lot of studies have shown that when a person has a relationship with a primary care physician, they have better outcomes in terms of their health, they have better costs, and they're happier and they're much more productive in society. So this medical home model is going to allow us to begin to re-engineer primary care to focus on outcomes and rather than just producing volume of services and high costs that we have today. In the United States, we spend around 17.5%, almost 18% of our gross domestic product on healthcare services. And that is double the next closest developed country in the world. And our outcomes are amongst the worst in the developed world as far as quality outcomes, as far as longevity. We're right in the middle of the pack. So we're not getting good value for the dollars that we spend. And the quality in America is not worth the money we're spending. And it's not we're saying the doctors aren't doing a good job. They're doing the best they can. But the model they work in, the system, the way it's designed, is not designed for the chronic care that we're seeing so much emergence of over the last 20 years in America. Things like diabetes and heart disease and hypertension. People are living longer, and the system was not designed to take care of those things. And because of the obesity epidemic, we're seeing these diseases much earlier in a person's lifespan than we ever did before. So again, the system, the healthcare delivery model that we have today is really an acute care system. It's focused on taking care of people with, acute diseases, with injuries, things of that nature, not for people with chronic diseases that basically start when you're, say, 30 and go through your entire life. So we need to change that delivery model that focuses on that type of chronic disease.
This is really important at the level of a state from the standpoint of your economic development. If you can't get a grip on the spiraling cost structure, you're going to lose jobs. It's really important to you. I mean, there's examples now where large corporations are looking at places where this kind of care is being delivered and a better value proposition is being delivered, and jobs are going there. Great example. Blue Cross Blue Shield working with Palmetto Primary Care in South Carolina, instrumental really in helping to attract Boeing. And we see tremendous efficiency in delivery of care and reduction in cost in that population. And so those are the kinds of things that corporate America are beginning to look to. So it's no longer just a health issue, it's really an economic development issue to be able to get at delivering a better value proposition in care, able to coordinate care better, be able to keep patients out of the hospital who should be kept out of the hospital. Example of that is Blue Cross Blue Shield in North Dakota. We've seen them manage their diabetics well enough that we've seen a 60% reduction in the necessity to do amputations on those diabetics. I mean, that's not only a huge cost savings, but a huge human dilemma savings, right? I mean, that's Zsa Zsa Gabor having a leg to stand on.
Well, the idea of this summit was to really begin to socialize the message that Blue Cross Blue Shield of Louisiana is embarking on a journey along the lines of this patient-centered medical home, where we're going to begin to reintroduce primary care into the communities, because we realize that primary care is a very, very important part of good health care. And unfortunately, over the last 20 or 30 years, it's sort of gone by the wayside because everything's been focused on specialty care and procedural care, and we're finding that we're not getting the outcomes we deserve. And a primary care physician, once they develop, like I said earlier, that relationship with the patient, that relationship is pretty sacrosanct. It's almost as close as the relationship you have with your family members, with your mother and father, your brothers and sisters. And if we can foster that kind of relationship, we're going to see that the physician can really work to engage that patient to help them start to change some of the bad behaviors that we as Americans have developed over the last 20 or 30 years that are driving this obesity epidemic that we're seeing in this country. This is going to be the wave of the future. We are no longer going to continue to pay physicians just to produce volume and not good high-value outcomes. We need to, begin to focus on better value, better outcomes, and we need to develop a model of delivery that rewards physicians for doing the right thing at the right time, the right place, at the right cost. Today, there's no accountability in the current model. There's no good coordination of care, and it's not really comprehensive care. It's episodic care, and it's focused on individuals. Under the patient-centered medical home, the physician is held accountable for taking care of a population of people. And you manage people a lot differently when you're taking care of a population. And what's really important about this is now, with all of our information technology capabilities, electronic medical records, et cetera, we are able to get information into the hands of the physicians that help them manage that population much more efficiently, effectively, keeping them out of the emergency room, keeping them out of the hospital, giving them more productivity at work, helping them lose weight, helping them, just really improve their overall life. And right now, the way we're doing care today, we don't have that type of delivery model. So once we change to this delivery model, and if you listen to what Paul Grundy just said, this has been going on for about 5 years now in America, and the early adopters are showing incredible results in terms of reduced costs, reduced ER utilization, reduced hospital readmissions, hospital admissions for ambulatory sensitive conditions that don't need to be seen in a hospital, and patients are much more satisfied, and doctors are much more satisfied. So it just makes sense that we're now starting to take lessons from some of these countries that spend half as much as we spend in America and have significantly better outcomes. We're starting to take lessons from places like Denmark and say, hey, it's been working there, let's try it in America.
It's that interaction that everybody is working together on my behalf to improve my health that I really, really appreciate. And in my job, I have the opportunity to help facilitate bringing about that patient-centered medical home to Louisiana. I think it's a good system. It's a good type of care for everyone here in the state. And it doesn't really seem to matter if it's a private practice or if it's a larger practice. I think that there are components of the program that everyone can benefit from.